Yeah, we're going to dive right in here. In terms of the focus of what we're looking at here, situating suicide prevention or gatekeeper training within the PBIS framework, just a couple of quick comments up front. First of all, how many of you are involved in providing technical assistance to multiple schools? Or is everybody here mostly actually, okay, so one or two people. And then most everybody else is here representing either a school building or school district, I would presume. Okay, that's helpful. So one of the roles that we play at the McDowell Institute at Bloomsburg University is beyond what we do with educator prep programs at our institution as well as across the Commonwealth, is provides a lot of support in collaboration or partnership in schools and districts around a number of different kind of social, emotional, behavioral wellness initiatives, implementation of the PBIS framework, and the like. And encouragingly, not surprisingly though, is an increased focus and request or an awareness at the school district level for the need to actually situate suicide prevention training within what they're doing with their multi-tiered systems of support. One of the common phenomena or things we run into, I would say at least 90% of the time in working with schools around this, is oftentimes the impetus for wanting to bring these types of trainings and embed them into school operations is a combination of either just compliance with Act 71 requirements that now exist in the Commonwealth of Pennsylvania, and or two, in response to increasing degrees of crisis situations that they've experienced either with their students or neighboring school systems have, all the way up through and including suicides of youth. For example, this past year, we've been working with two school districts in particular within the immediate region where we're located, where they've had 2 youth suicides within the last 6 to 12 months. So that created a real kind of crisis level response need, of course. And it's challenging at best to talk about prevention and promotion when you're in the heels of really postvention rather than prevention. So we want to frame what we're going to talk about here today in acknowledging that there is a whole continuum of practices and programs and thought process that needs to go into suicide prevention and particular suicide prevention training. It's not just as simple as we're going to do youth mental health first aid, or we're going to do question, persuade, refer, or we're going to do this virtual learning module and have all the staff completed online within 12 months and then, okay, check the box off, we're done with that, we've done suicide prevention. But rather to really get at suicide prevention in a sustainable and meaningful way, you really need to look at integrating it and embedding it across the multiple tiers of your PBIS implementation. And the good news is a lot of the endeavors that align with PBIS implementation already align with suicide prevention initiatives, right? And that'll become a little bit more clear as we go through some of the examples that we talk about today. So while we will talk about, in particular, 2 evidence-based suicide prevention trainings that we're heavily involved with in schools, being youth mental health first aid and question, persuade, refer, we're not going to limit what we focus the conversation on today to just youth mental health first aid and QPR training, because that would be, I think, misleading in terms of it's really shouldn't be an approach of just we've done this training, now we're good for X number of years, and then we'll cycle it back through, even though it's kind of a part of the process or the requirement. So with that, now I would imagine most everybody here that's coming to this particular session already has some orientation to the increasing relevance of the need for suicide prevention training, but I'm going to do a couple just quick obligatory slides here that kind of reflect some of these data patterns that we're seeing nationally as well as in Pennsylvania, just to punctuate the point. So this will not be exhaustive by any means, but it does kind of put things in perspective. The one thing I will emphasize, though, is that this is not unique to youth, that we are literally in the United States, and we don't have data to go in. We have data, but it's not incorporated into this presentation. This is a public health crisis in the United States that we're confronting. This is not just an anomaly. It's not just a blip on the screen, and we can absolutely assure it's not going to get better by itself. Also in the United States, our data patterns are very different than data patterns in most other highly developed countries globally. Real quick point on this front is that over the past 30 years, there's been a gradual decline globally in most highly developed countries in terms of suicide across the board, all the way up through from young ages all the way up through senior citizens. In the United States, we have an inverse relationship, that our trend is going upward and upward and upward in that same time frame. So this is something that's perhaps to some extent a bit unique to our country and our culture and a variety of different factors. I don't think anybody knows what the cause is, and I think the one thing we know for sure is there's not one cause. It's a complex set of issues. So the reality is, as educators, this is going to be part and parcel increasingly of what we need to do. So when we look at the national statistics on suicide, on average, one suicide every 12 minutes. So just about not been here 12 minutes yet, but almost within this time frame, there has been a suicide in the United States somewhere. One attempt every half minute, approximately 129 suicides per day. In 2017 alone, over 47,000 people died by suicide in the United States. 10th ranking cause of death in the U.S., over 1 million suicide attempts in 2015 based on those data. 25 attempts for every death by suicide, and 4 female attempts for every male attempt. However, there is an inverse relationship in that males are 4 times more likely to die by suicide than females. So higher attempt rate with females, higher death rate in terms of males. The national youth suicide data, suicide's responsible for more deaths among 10 to 24-year-olds than all other natural causes combined. It's the second leading cause of death in youth ages 10 to 34. Young adults obviously are included in there. This last data point here, age-adjusted suicide rate for most rural counties was 1.8 times higher the rate than urban counties. So in some ways, and Pennsylvania is densely populated in certain areas, but the majority of school districts are actually rural in nature, that when you look at it from an age-adjusted suicide rate level, that actually being in rural counties actually is an increased risk factor, is maybe a way to look at it. Pennsylvania youth suicide data in particular, this is based on the most recent round of the PBIS, Pennsylvania Youth Survey. Danielle will talk a little bit about that in a bit. In terms of suicide, about 16.5% of students, so 6th, 8th, 10th, and 12th graders in 2017 that responded to the PBIS had indicated that they had considered suicide. 13% had a suicide plan. 10% reported that they had attempted. So that's 1 out of every 10 kids that responded to the PBIS in the Commonwealth of Pennsylvania had reported that they had actually attempted suicide. And those data, when you look at them from 11 to 13 to 15 to 17, are trending upward. So that kind of sets the stage to talk a little bit about situating suicide prevention within the PBIS framework. So as we've been, and probably for about, I'm thinking a little bit over, just about 2 years or 2.5 years, we've been partnering with colleagues from the Office of Mental Health and Substance Abuse Services, or OMSAS, and in particular the Garrett Lee Smith initiatives, or suicide prevention initiatives, operated across the Commonwealth, to really start to look at the alignment of things, including student assistance programs and the PBIS framework, but then in particular explicitly around suicide prevention. So when we think about this, there are a number of factors related to school-based suicide prevention endeavors that are really, really important to consider and to think about in a really explicit manner. First is, what are the policies and procedures for prevention, intervention, and postvention? It's not sufficient to just look at what do we do in response to. It's not simply sufficient enough to look what do we do at how to prevent and promote. You need to look at the entire continuum of what are we going to do from a prevention promotion standpoint, And then what are we going to do from an intervention standpoint when we encounter a particular youth that's in crisis or appears close to in crisis? And then what do we do on the postvention side? Postvention relevant to either an attempt or, worse yet, a death by suicide. And there are a number of resources that are available, particularly in the postvention side, because then, as you know, when any of us are in crisis ourselves, it's really hard to learn new things at that moment. We're really responding and trying to do damage control. There are some very, very good resources that provide guidance for schools on postvention policies, but also actually drafted letters of how to communicate with families in the community, how to reach out to perhaps the family that was affected directly by the loss of a child, or if not the loss, by the attempt of a child. And those resources, the time to gather them and build them into a compendium of resources at the district level is prior to a crisis, not at the moment of a crisis. And unfortunately, I know we can speak firsthand for this. The two school districts that we've been supporting pretty heavily this year, they were building it as we were going. So we were like, okay, even getting to the point of drafting letters for them that they could review to consider to send out, because they just didn't have the postvention side or the policy sides kind of pulled together. So while none of us want to think about postvention, please think about postvention in this process in the event that unfortunately that you might have to entertain it or engage in it. Beyond those policies and procedures running from prevention through postvention, we're talking about education for students, staff, as well as families in the general community, and I would argue that includes school boards, and then also screening and assessment procedures. So we heard this morning, for example, talking about universal screening when Kathleen Lane was talking about that, and then some of you may have gone to her follow-up session. So the issue of putting in place both universal screening and then also targeted or indicated screening on a follow-up to that fits into a suicide prevention framework, a suicide prevention approach. So when you think about situating these types of practices, so to speak, across the continuum of the multi-tiered framework, you want to strategically think about how do they sort or situate, much in the same way that we talk about how do we sort and situate the evidence-based practices associated with PBIS implementation. So at the universal prevention level, what we have here is gatekeeper training for staff, students, community members, and the like. And we're going to talk specifically about gatekeeper training or suicide prevention training in a bit here. In addition to that, though, we also need to think about and be aware that it's not just about that training. Everything that you're all currently doing with implementation of the PBIS framework with fidelity is a form of suicide prevention at Tier 1. If you're implementing or installing or planning on implementing an evidence-based social-emotional learning curriculum with a bully prevention component, with a substance abuse prevention component with it, these are all part and parcel of a suicide prevention approach. They also should be aligned with your Act 339 plans in terms of school counseling programs. All of these things align, but they should be situated or thoughtfully, strategically positioned within your PBIS framework. Then, of course, you need to have layered on top of that for kids that might pop, so to speak, through some type of screening mechanisms that you have in place. You need mechanisms to do targeted training, targeted screenings, and targeted interventions and supports for those kids. Here's where that relationship with local mental health providers really comes into play. Some schools have gone the route of already establishing school-based behavioral health, whether they're the provider themselves or they have a working relationship with a local mental health provider, and that local mental health provider is on school grounds, or they have a working relationship with a community-based provider that might come into the school to provide services, or it's just a working relationship with a community-based provider and the services and supports are provided off school grounds. There's not a one-size-fits-all or one model, but the key to understand is when you're getting into the targeted level and most certainly the individual intensive level, for kids that have significant needs in terms of suicidal thoughts and/or attempts, you need to have a working relationship with your mental health system and your mental health providers. And that includes policies and procedures such as memorandum of understanding or letters of agreement between the agencies? How are you going to navigate issues of confidentiality? As well as then how are we going to embed and share information between the school system and the provider system, obviously in working with the family, and depending on the age, right? Because we know 14 is the magic window of age for kids in the mental health system, how we navigate that with kids as well. So all of these things are, or go beyond is probably the best way to put it, go beyond just how do we put suicide prevention training in places as if it's a standalone piece that isn't somehow embedded into a larger infrastructure or a framework. So just as everybody is increasingly being encouraged to look at alignment between, say, student assistant program operation and PBIS implementation, in terms of the framework, just as we're being encouraged and we're encouraging people to look at an aligned and integrated educational MTSS or academic MTSS, as well as behavior support through the PBIS framework. We're talking about situate within that as well, suicide prevention. Don't view suicide prevention as this standalone thing that sits over here by itself, but view it as part and parcel of your approach. So let me turn it over to Danielle, and she will talk a little bit about the interconnected systems framework.
Yeah, so Tim laid it out really nicely that when we talk about situating suicide prevention within the PBIS framework, we're talking about a true integration across all of the tiers with our staff, across the board that works within our program or our school, and with our students. So how many of you have heard about the interconnected systems framework, or the ISF? Yeah, a few of you. Absolutely. So just as Kathleen would really highlighted and drove home the importance of integrating to make sure that we're impacting the whole child and we're meeting the needs of the whole child, we want to make sure that we're equally providing a structure and a process to align and integrate PBIS and school-based mental health. So when we look at the core features of what the ISF lays out in conjunction with the core features that we're very familiar with around PBIS, we see the following. So the ISF really enhances our MTSS core features in that we're looking at effective teams that include those community-based providers, as well as data-based decision-making, and again, not a new concept, right? But we want to go beyond just our ODRs. We want to look at community-based data as well. And we're going to dive a little bit further into that in terms of what types of data we be able to pull from. As well as we want to make sure that we have a formal process for selecting and implementation of evidence-based practices, and understanding that that should be a team-based decision, that it shouldn't be dictated by one individual. We want to highlight that there's early access through comprehensive screenings, again, which Kathleen hit on quite extensively this morning, really understanding that we need to address both internalizing as well as externalizing needs of our students. We want to make sure that we have rigorous progress monitoring to ensure that what we're doing is effective, as well as meeting the needs of our students along the way. And we're going to have continued ongoing coaching, knowing that our needs of our students may in fact change based on the climate that we're in, the community that we're in, and as our staff members begin to change. So the one that I'm really going to highlight right now is data-based decision making that goes beyond just our ODRs. So when we talk about that, we talk about pulling our SAP data and really making sure that we're bringing that in and looking at that systematically along with those ODRs. Looking at trips to the nurse's office, absenteeism, as well as additional pockets of data that we're already pulling from, some that is more compliance oriented, right, that we're already asked to gather. Schools have tons and tons of data, but sometimes we don't systematically really look at what we have and to say, how can we use all of this data that we're being asked to collect to better service our students? So the one that I want to highlight in particular is the PAYS, or the Pennsylvania Youth Survey. How many of you know if your school district is using the PAYS on a regular basis? A few of you. How many of you, out of the a few that actually raised your hand saying that our district is implementing the PAYS, have you gotten access to the data? Post? That's great. We've found that a lot of districts, because there's about 80% of the Commonwealth that are voluntarily utilizing the pays, they aren't sharing that data with their teaching staff as well as paraprofessionals, and or sharing that with the community. It ends up really kind of sticking within the administrative team, and it's not going farther beyond that. But what's really wonderful about the pays is it's quite comprehensive. So it looks at risk and protective factors in the community, in the school, in the homes of the students that are anonymously participating. So the PACE takes about 45 minutes for a student to fill out completely, and it's symmetrically sound. So it's quite extensive in that, and it's 6th, 8th, 10th, and 12th graders done on a biannual basis. So it is quite comprehensive. It's not done annually, but it does provide the district a pretty big wealth of information on what's going on from our students' perspective in our schools and in the school climate, as well as what's going on in the community. How are they feeling about the type of community that they're living in? Do they feel safe? Do they feel as though that their family has enough resources, or are they concerned about that? So really looking further into beyond just what's going on day to day within our school, looking at the extensiveness of the child's everyday ebb and flow in the world around them. So I want to share with you, and I know I'm really testing your eyesight here on this one, so I'm sorry about that. Some data that we have been in terms of working with one particular school district, some of their PAYS data and how they've identified targeted areas that they're focusing on for the next 4 to 5 years, that they want to start to bridge those gaps in terms of the needs that their students were sharing based on their PAYS report. So their priorities reflected around mental health and risk for suicide, and I'll just share with you one of their kind of data points is 4 out of 10 students indicating that they had felt sad or depressed most days in the past 12 months. So out of their 6th, 8th, 10th, and 12th graders, a large portion of them, or 44.5%, had indicated that they had felt sad or depressed for the majority of that year. And that was a really big data point for them to say, wow, what are we doing? How do we help them not feel this way? And how do we help support their mental health within our school? Another priority area were experiences with bullying, being threatened with violent behavior in the school grounds, as well as substance access and use. And the last one was stress associated with limited family resources. This particular school district, not unlike many districts in the state of Pennsylvania, is very rural in nature, spans across 2 counties. So in terms of access to resources, it depends on where the student lives at times, right? That makes it very challenging. And the median income for that area was around $30,000. So it was a very big kind of moment for the administrative staff to say, we need to look at how can we help our students, how can we help our community, and how can we help our parents, because we know that we can't do this alone, and we need to work together to help to build and kind of close the gap around those needs areas. So we really encourage heavily, because sometimes when you see data like that, we automatically want to say, what can we do? How can we help? How can we fix that, right? That's the helpers inside all of us. We don't want kids to be struggling. We don't want to see anyone struggling. But we encourage you to take your time and really be systematic about developing a plan in terms of how are you going to, across the board, start to address some of your needs, and really making sure that you're using data to drive those decision-making processes. So we've utilized a logic model to help districts navigate through some of those data, especially when you're gathering from various buckets of data, right? So if you're using the PAYS, if you're using your SAP data, if you're looking at your ODRs, that can become really overwhelming. So having a way that you can sit down as a team and really start to assess what is our data indicating to us, our needs and our gaps, using that data to make informed decisions about what are our goals for the next year, the next 3 or 4 years, the next 6 months, however you decide as a team you want to go about starting to address some of those needs and or gaps. Because sometimes what we like to do is we start saying, okay, what activities, what types of curriculum can we do, we get a little bit ahead of ourselves and we don't start to see how can these all start to cluster together to make the biggest impact. So we want to take our time, we want to start to build those objectives, start to identify systematically what's our goal for our impact and our outcomes, and how are we going to make sure that we're meeting those, making sure that we're really honing in on what are those measures, how are we going to know that we've met our goals as a team with whatever we're doing. Then start to fill in what are those activities, what are the curriculum, the programs, services, strategies, or policies that we might need in order to make that goal a reality, as well as what types of partners and or resources are we going to need, in addition to how are we going to progress monitor that we are in fact achieving those goals. And then once you fill out your logic model, then you'll move into really detailed action plans for each activity that you've laid out, really making sure that you know if I'm doing step 1 of step 50, that I've made sure that I kind of pass that baton off, that it's really systematic in that way. Everyone knows and everyone's aware of who's doing what, who's responsible for what, and how are we tracking that and sharing that information with one another. So Tim is going to kind of move us into the next core feature of the ISF that we're going to highlight.
So that key piece there, of course, is minimizing the chance that we just try to dive in the pool and start doing a bunch of activities to address the issue, but really to try to work smarter. And the real focus of this is sustainability. What we don't want to do is, with a sense of urgency, all of a sudden jump in and do a number of things that might intuitively make a lot of sense, and they might even longitudinally make a lot of sense, but they're not sustainable the way we build them from the onset. And then we just reinvent the problem, and then we have to reinvent a solution and reinvent the problem and reinvent a solution, so to speak, moving forward. So with that, the Interconnected Systems Framework is really a way to kind of help us navigate to enhance the PBIS framework beyond but inclusive of suicide prevention. Now we're focused on suicide prevention specifically here. So the next feature I'm going to take a look at is a formal process for selection and implementation of evidence-based practices across the tiers and team decision making. And here's where we'll start to get into some of the details of the gatekeeper trainings as well as other types of preventative and promotion types of endeavors. So one of the things we've also found is, not surprisingly and completely understandable, that a lot of times there isn't an established process or protocol at the school building level in terms of how to actually go through, and Kathleen alluded to this morning in her keynote as well, to actually look at the array of evidence-based programs and practices that align with addressing the needs that you've identified through some strategic planning process. So what often happens, or what often drives the selection of, we're going to do this social emotional learning curriculum, or we're going to do this gatekeeper training, or we're going to do this bully prevention program, is someone learns something about it, brings it back, and people say, that's great, that'll address this, and they all dive in and they start implementing rather than strategically going through a thoughtful decision-making process. There are an array of evidence-based gatekeeper training programs, social emotional learning curricula, universal screeners to select from. So the key becomes becoming an informed consumer at the district level and particularly at the building level for implementation. So that second feature in the Interconnected Systems Framework is applying a protocol. One of the evidence-based protocols that does exist out there to guide this is known as the Hexagon tool. That was developed by Karen Blase and a number of her colleagues. And this is a conceptual snapshot of how this particular protocol or decision-making process plays out. It's essentially a rubric, so to speak, that lays out, in their case, 6 different domains. They look at kind of the need of the district based on the data. You look at the kind of contextual fit of how does this evidence-based program actually fit with our culture, our community, and our operations in the school. It also forces you to kind of think through what are the resources involved or required. Do we have to purchase a curriculum? What are the training costs associated with that? Are those things that we can absorb, and not just absorb to launch, but to sustain over multiple years? It also forces us to look at the evidence behind it, because when we say something is evidence-based, well, that kind of gets loosely defined. As we know with ESSA, for example, there are different levels of what we might call evidence-based or research-based training. So it looks at what is the empirical evidence behind this. And keep in mind that there are not a lot of programs that have good face validity. Intuitively, they make a ton of sense, but that doesn't necessarily equate to there is a longitudinal database that says, yes, in fact, there's efficacy behind it. That doesn't mean you should discard it out of hand, but it's a factor to consider before just adopting it. Because all evidence-based programs begin as promising practices. In other words, they're not born with an evidence base. The evidence base evolves over the course of time. It also prompts us to look at readiness. Where are we at with implementation? For example, if you're in the first year of implementation of the PBIS framework, you probably are at a different point in capacity than if you've been implementing for 3 or 4 years and you're actually looking at fidelity now at the advanced tiers. So these are all logical things to consider. They are variables that will influence both initial implementation as well as sustainability. We look at the current capacity in terms of what are we currently doing based on what data we have, in terms of are we being effective with what we're doing? Are we utilizing our resources in a way that makes sense? A good example of this is looking at how do we currently use the FTEs we already have? How are our guidance staff being used? How are our school psychologists being used? How are our social workers being used? Or are they increasingly having their time kind of chipped away an hour at a time and a day at a time to do other administrative duties that have to get done, but as a result, they're less available to actually provide the things that their expertise uniquely qualifies or positions them to be able to do. So all of these areas are component parts of what's known as the hexagon tool. We learned about the hexagon tool back around 2013-14 through implementation of a SAMHSA grant at a number of schools across the Commonwealth known as PA Safe Schools and Healthy Students. As a result of those experiences, and the hexagon tool is a really solid tool and it has an evidence base. One of the things that we found through implementation, though, was that its design and its structure didn't always align really well with how at least the school systems that we were working with in the Commonwealth of Pennsylvania were kind of organized to operate. And based on feedback and working with them, we decided to kind of spin off a hybrid tool, utilizing the same component domains or parts, but building it into a kind of like a line of inquiry or a series of questions all on one data collection sheet. And it cuts across the exact same domains that the hexagon tool does, but it adds a couple additional features as is advocated by a number of the colleagues involved with the National TA Center, the OSEP Center on PBIS implementation. The key to understand with the hybrid tool, the hexagon tool, or any other protocol that you might consider at the district level is that it's going to yield some type of a score, typically a numerical score. It is very important, at least based on our familiarity with the tools that are out there, that the score is used to guide a focused conversation, but not as a firm cut score, so to speak, in terms of, well, this particular evidence-based program scored 19, this one scored 18, the 19's higher, that's the one we have to implement. Rather, it's a way to kind of organize and kind of discard the outliers. Maybe one of the evidence-based programs being considered is a much, much, much stronger fit for a district, so it helps to identify that sooner rather than later. Or there may be one that's an evidence-based program, but it scores particularly low from a capacity and contextual fit need, and therefore the district might be inclined to say, okay, in theory and in the literature, that's a solid tool, but we don't think it aligns with the culture and our community environments and our school operations. So the numerical scores kind of guide the process, to guide the conversation, to make a decision that should be some type of team-based decision on what to implement. Now, a protocol can be applied with lots and lots of different types of evidence-based programs that you're considering. So to illustrate, at the particular case example Danielle alluded to in that one school district, based on their data, here were the emerging priorities that this school district decided to really prioritize in years 1 and 2 of their implementation. They needed to identify a social emotional learning curricula, ideally one that would run pre-kindergarten because they wanted to get into their feeder early childhood ed programs, all the way up through high school, and then they would stage and phase that in over multiple years. Well, there's lots of social emotional learning curricula that are evidence-based to consider out there, and all of them are very solid given an evidence-based. They considered a variety of them, and they eventually arrived at the decision of going with positive action. Now, that doesn't mean that positive action is always the right fit for a district. Maybe second step is a better fit. Maybe life skills is a better fit. It depends on what the circumstances in the district are. That's where a protocol helps you to guide that decision making. They arrived at positive action. The second area was they were committed to, we need to start to roll out some type of systematic universal screening to put that in place. And they have started to look at a variety of different screeners, and while they've not rolled them out yet, it's quite likely that they've arrived at looking at the SSRS with the internalizing and externalizing features or factors. Again, Kathleen talked a little bit about this particular screening tool this morning. And then in addition to that, one of the other areas that was a logical priority for them based on their needs, because their PAYS data, it indicated that I think it was around 21% of their respondents had indicated that they had considered suicide in 6th, 8th, 10th, and 12th grade as compared to a lower percentage rate at the state level. They decided that they needed to formally roll out some form of evidence-based suicide prevention training. So when they started that conversation, they're like, well, we need, because the only thing they knew about was youth mental health first aid. And they're like, we need youth mental health first aid, we need it for all our teachers. So I'm like, well, okay, even if you could do that, logistically, the challenges of doing that because of the constraints of that 8-hour curriculum that Danielle will talk about is prohibitive at best. That doesn't mean youth mental health first aid is not a solid program and it shouldn't be a part of a continuum, but there are a variety of different evidence-based programs that one could align for gatekeeper training. So that set the stage to look at a combination of some staff getting youth mental health first aid, some staff getting question, persuade, refer, along with some other types of value-added learning experiences that were supportive to them. So with that, I'm going to turn it over to Danielle to talk a little bit about the gatekeeper trainings.
The mic handoff, right? It's always clunky. It's okay. So what I just passed around are some key questions that we found are really helpful when we're engaging with a district or just a particular school around them being interested in wanting to do some form of suicide prevention training, to really start to dive a little bit further for us to have a better sense of what are their needs, what exactly are they looking for, and to make sure that what we can offer is the best fit for them. And frankly, that it's going to be sustainable for them over time. Like Tim said, we run into a lot of districts that'll say, we want all of our 120 staff members to go through youth mental health first aid. Well, that sounds really great, but that becomes really logistically challenging when you start to look at the details of youth mental health first aid. And other things you want to start to consider are you only looking at instructional staff, or are you going to expand that further into clerical support staff, as well as district administration, cafeteria workers, paraprofessionals, bus drivers? How systematically are you going to look at building mental health literacy and suicide prevention across your district or across your building? So when we talk about gatekeeper trainings, we're talking about training that is really for the general public, just like CPR is on the physical health side. So we're looking at individuals that have no clinical background. They in fact can, right, to go through the training, but it's not a requirement for you to have a clinical licensure at all to engage with this. It really provides individuals with some skills and some confidence in order to support an individual who's in some level of emotional distress and or crisis at that point in time, and understanding how to navigate getting them to the appropriate professionals. So yes.
Is there a level of grade level that this is geared toward? Is it more secondary or is it all levels?
Yeah, so she asked if there was a particular grade level in terms of just gatekeeper trainings in general. Yeah, so it depends on what you're looking at in the type of program or training packet. For mental health first aid is coming out with a teen training. It's in its pilot phase, but that goes as low as 10th grade. QPR will go, I believe, age 16 and up. So it really does depend, but there are other ways to get at building those social skills and help-seeking skills at a younger age as well that might not be traditional gatekeeper trainings. Absolutely. So Tim highlighted that in terms of the case example, this school was really interested in youth mental health first aid as well as QPR. Tim and I are both credentialed in both youth mental health first aid as well as QPR, so we're quite familiar with this. And in terms of the Institute, we particularly gravitated towards these two gatekeeper trainings because they have a pretty strong evidence base behind them, whereas a lot of suicide prevention trainings to date don't. They have really great face validity, but there's not a lot of longitudinal data to show that the skills that individuals are learning throughout the course of their time within a training actually translates into them utilizing those skills in a crisis situation. So both youth mental health first aid as well as QPR do have a pretty strong evidence base. So with youth mental health first aid, how many of you have you gone through a youth mental health first aid training? Are you familiar with the training and or the adult mental health first aid? A few. Okay, so for those of you that have gone through, you've gone through the 8 hours, right? It's a pretty long day if it's not broken up into 2 fours. So it is quite comprehensive. The day usually starts with getting individuals a little bit more familiar with mental health in general in terms of what might that look like for typical adolescent development as opposed to when somebody might be showing signs that they're struggling or might need additional supports to navigate through a particular situation that they're in, and or in fact maybe they are developing a clinical diagnosis. So it really looks at what is typical adolescent development as compared to when somebody may be starting to show signs that they are maybe in distress and or developing a mental health condition. So throughout the course of the day, you work in teams to develop skills along the way using the ALGE action plan, so assessing for risks of suicide or harm, listening non-judgmentally, giving information and reassurance, as well as encouraging appropriate professional help and encouraging self-help and other support strategies. So it looks at both crisis situations as well as non-crisis situations and how to use the ALGE action plan to navigate your way through that, and how working with one particular individual that's in distress or in a crisis might not be the exact same steps that you use with someone else. It really is all situational at a moment in time. So this is a very comprehensive training. It's a very long training. We encourage districts to really start to systematically think about who might be those targeted staff members you want to have go through a comprehensive training like this, understanding that it's quite pricey, it takes a lot of time for an individual to go through, and based on their own personal experiences, it might not be healthy for them to engage with at a moment in time. Or they might not have enough background knowledge to feel confident in going through that level of training. So really understanding where your staff is at and how to make sure that you're selecting the right individuals to attend that type of training. So with question, persuade, refer, or QPR, it's a more reduced training. It takes about 2 hours. Some individuals conduct this training in 90 minutes. It really all depends on the length of the simulation at the back end of the training that individuals go through and how long an instructor might have their class go through that. So with QPR, it really does highlight some of the same key components that youth mental health first aid does, but it really only highlights them in a crisis situation. So it doesn't look at non-crisis situations, but really if an individual's in immediate distress, how do you help them at that moment in time to de-escalate, as well as persuading them to seek appropriate professional help and then referring them along the way. So really this is more focused in on direct suicide prevention. As with mental health first aid, it's across the continuum of mental health and literacy building. So we did a little comparison for you just to give you a better sense of the cost of these trainings per person and have a credentialed instructor come in, as well as the time commitments and how in fact someone might go about getting credentialed. So with QPR, you can do the credentialing process in two ways. You can either do a traditional face-to-face or you can do it virtually. So that makes it a little bit easier if your district is interested in looking at getting a particular staff member credentialed in this training to be able to have the on-site ability to funnel your staff through. It is about $500 for an individual to get credentialed, and it does have a little bit more flexibility in terms of the amount of participants that are able to be in a particular training. QPR can go up to 40 at a time, where youth mental health first aid is really strict on no more than 30 people in a room. QPR, in terms of the materials to conduct the training, is about $3 per participant for a little pamphlet-like book that you get, whereas youth mental health first aid, participants leave with an entire textbook, which is a really great resource, but it's about $20. So it does come quite costly, especially if you run through an 8-hour day and you have all the individual staff time as well as food and the such. Yes?
Bellhaven, it's a local mental health facility. They did have a grant that offered the training free to certain individuals who wanted it, so I'm not sure if that's still available.
Yeah, so she was sharing that there was a local agency that provides youth mental health first aid, or was it both?
I'm not sure if they do both, but I know that Bellhaven had a grant from the state in which they offered it free. I took it free.
Yeah, and there are quite a few either philanthropic-based agencies that offer trainings for free or at little to no cost, as well as there are numerous state entities that have grants and or state-level grants that offer trainings for free. It's very true. That is something to be mindful of if in fact you're looking for those trainings. But they can be really hard to get into, knowing that a lot of people are really kind of clamoring for these types of trainings. But that's a really great point, and I'm glad that you did bring that up. Yes?
For example, like with the trainings we do, because of the way we're underwritten and structured, we don't charge a fee for the training. We're philanthropically supported, so when we provide a training to a school district, they don't have to pay a fee for us to do the training. Sometimes we can leverage resources to cover the cost of their books for them. Sometimes they have to cover the cost of their books for themselves. They always have to cover the cost of their staff time. Other places, though, school districts that are looking for training are kind of on the market looking for training, and they might pay anywhere, depending on the nature of the training, like QPR could run an additional $500 to $1,000 for the training itself. And one of the things Danielle alluded to earlier that I just wanted to reemphasize is that whenever we provide any of these trainings, we always co-instruct. And the primary reason for that is it is not atypical for participants in the training to have a strong emotional reaction to the curriculum based on their life experiences. And as a result of that, that has one of us available to actually administer QPR or mental health first aid to that person outside of the room. That is not an anomaly. That happens more times than it doesn't happen. So if you're thinking about contracting out to have somebody come in and they're going to charge a fee, highly encourage you to consider co-instruction, which is going to double your fee cost because you're going to have 2 instructors now on site. The other thing would be, I would always encourage you to add additional layers of support of staff who know staff there as kind of in the wings available to provide that support.
Yeah, absolutely. Thank you for kind of filling in some of those gaps that I did leave out. And something that we do like to make sure that we highlight as well as once an individual becomes credentialed, it is really important to make sure that you're aware of how frequently it's going to be that someone has to re-up their certification. So for youth mental health first aid, it's every 3 years that your staff would have to go through and complete the training in some manner or another. So it can become quite costly over time when you're running multiple staff through. So again, we really do encourage you to dive further into looking at systematically some of those questions that we laid out. We know that those are not an end-all be-all, but they do help you to start really thinking about what is the actual cost of these, who are the right staff to start engaging with suicide prevention trainings, knowing that both youth mental health first aid and QPR are not the limit to what's available, but those are the two that we are most familiar with and really do endorse quite heavily. We want to make sure that you're choosing the right suicide prevention training for your district, your school, or your program that you're working with. So Tim is going to kind of highlight some of the data in terms of progress monitoring.
Thanks. So the other thing too, and most people have noticed this, but I don't know if we explicitly said it, these cost comparisons are what it costs to get somebody credentialed to actually provide the instruction. This is not a comparison of the cost of what it costs for people to actually go through either the 8-hour or the 2-hour training. If you're looking at sustainability and systematic implementation, and this is something that we encourage schools to do whenever we work with them, our goal is not to be the end-all be-all trainer for them in perpetuity, because we don't have the resource and capacity to do that, plus there's other districts we want to support. We usually try to encourage them to get 1 or 2 targeted people, and then what we do is we try to facilitate networking amongst the school districts that have 1 or 2 credentialed instructors in these arena, and we'll provide support to those trainers, and then in turn they train their own staff moving forward. But a lot of times we end up being the initial one-stop shop. But our first goal and kind of negotiating point is we can help you now, but we want to help you to figure out how to help yourself long term rather than always coming back to us, because we've got lots of other things we need to be doing, not just gatekeeper training. And if that's all we wanted to do, we could be doing gatekeeper training 7 days a week, I mean, at this point in time. So taking one last kind of thing we want to look at, and Danielle alluded to this a bit, and that's another key feature of the interconnected system framework is this rigorous progress monitoring of both fidelity and effectiveness. Another way to say that is access to say mental health services or access to training is one thing, but the question is that program that's being accessed actually having the desired impact, right? That's really where the rubber meets the road. So what I'm going to briefly share with you is our approach to how we're looking at efficacy data as it pertains to youth mental health first aid in particular. And we've also started to explore this with the QPR training as well. Now, the data I'm going to share with you, I want to be really clear up front. One other major feature of what we do at the McDowell Institute is educator training or pre-service teacher training. So the database that I'm going to be sharing with you now is not school staff. It is the pre-service educator training programs across the 23 institutions of higher ed in Pennsylvania that we're working with right now that are embedding youth mental health first aid training in their pre-service teacher prep programs. But this same approach to looking at efficacy is applicable at a school district as well in terms of implementation. So what we've designed based on input from lots of people and kind of giving some thought to this issue of impact is a 2-stage or 2-phase survey that we follow up. We've put it on Qualtrics, so it's a virtual survey with, in this case, our pre-service educators. So for example, in the Commonwealth of Pennsylvania in the last 2 years, we have had institutions of higher ed credential just about 1,000 pre-service educators going into student teaching in youth mental health first aid. We expect to double to triple that number in this upcoming year because of the work that a lot of institutions are doing with us now on this front. So what we do is we put in place a voluntary survey that kicks out post-completion of the training to all of the participants. In this case, they're pre-service educators, right? Just prior to going into student teaching. The first survey looks at kind of basic types of question that looks at self-report of how has this training influenced your knowledge and thought process. These are a couple questions. This is not the entire bank of questions, such as a result of youth mental health training, I'm more aware of how social, emotional, and behavioral matters might influence student learning. As a result of youth mental health first aid training, I'm better able to effectively reach out to a student who may be experiencing a mental health challenge, et cetera, et cetera. So there's kind of a first survey that comes out a couple of weeks, 2 to 4 weeks post completion of the training. Then we also build in an impact survey that comes out about 2 to 3 months post the training. Now, we go with 2 to 3 months because they're pre-service educators and we only have them captive through student teaching. So you could, and ideally, I would ideally like to go a little bit more longitudinally and do like a 5 or a 6 month follow-up, but we would lose access to a number of them because they've walked across the stage, got their diplomas, and they're less likely to respond to surveys, right? So the impact survey looks at, since my initial training, have you been more sensitive to social, emotional, behavioral types of issues? And it's a yes, no, or uncertain option. And then since my training, have you applied aspects of the action plan, ALGE, as Danielle overviewed for you, with students and in school or community settings? And it's a drop-down menu of yes or no. For those that indicate yes, there are follow-up questions. Since your initial training, which aspects of youth mental health action plan, ALGE, have you applied? With how many youth have you applied it? So it actually starts to delve into what has this actually done in terms of behavior change with you and supporting students. So based on that, this is just a snapshot of some of the data. And this is based on roughly 120 respondents, primarily at one institution of higher ed. This just gives you a feel of the impact, which aligns with what the evidence base for youth mental health first aid training suggests. But in response, for example, as a result of the training, I'm more aware of how social, emotional, and behavioral matters might influence student learning. 2 to 4 weeks post, 92.9% strongly agree to agree. 1 or 2 small percentages disagreeing. And keeping in mind, disagreeing doesn't necessarily mean that they didn't think the training was of value. It depends on where they came in with a baseline. Some of the people, for example, in these trainings were in the school counselor training program. Some of them were dual special ed majors, and they've had a healthier dose of behavioral health issues, perhaps in their pre-service training, than, say, typical early childhood educators might in that track of their program. And then with respect to part 2, which is the impact survey data, and this is the stuff that we were ecstatic about because we really didn't know. This is kind of uncharted territory looking at impact of these trainings. We had anticipated there'd be an impact, but we did not anticipate the degree of impact that we would hear reported back from student teachers. Because keep in mind, they're as green as you get going into the field, really, right, in a student teaching placement. And out of 120 of the respondents that we got to both Survey 1 and Survey 2, so we could link the two, what we found was that out of those 120 respondents, roughly right around 22% of them indicated that they had applied primarily the first component of the action plan, about 16% component 2 as well. If you go all the way down, component 5 is getting all the way up, or 4 and 5 is actually dealing with kids that are in actual real crisis. And if you look at that, you're talking about, based on these data alone, an indication of close to 35% of them indicating that within about a 2-month window that they had actually applied the full gamut of youth mental health first aid skills that they learned with primarily kids in their student teaching placement. So those data just were, we didn't expect anywhere near that type of an impact, and that aligned with the anecdotal feedback we were getting from student teachers. We'd get unsolicited emails or contacts from co-ops of student teachers or supervisors of student teachers saying, my gosh, I had this training a week ago. I'm in my second week of student teaching placement, and I had a kid tell me he was thinking about suicide. And while I didn't know exactly what to do, I knew a whole lot more of what to do and how to go about supporting him as well as then navigating the system, where before they would have essentially been on their own to figure it out as they went along. So these data are pretty compelling, but I want to be clear that those data are pre-service educators. They're not staff in schools, but we would have no reason to think that you wouldn't see similar types of impact. The key takeaway would be this, though, is we would encourage you to look at having some type of impact survey data. If you're going to invest at a school district to have all staff trained in an array of evidence-based suicide prevention training, whether it's youth mental health first aid and QPR or Cognito or other types of evidence-based programs, measure the efficacy and impact of it as well. It's not that challenging or time-consuming to do that, kind of like the social validity data that Kathleen was talking about earlier today. Those data are really, really valuable data to get, because even if you get the training for free, quote unquote, for example, if we go into a school, our time comes free if we can leverage money and find a way to cover the books. And we've done this with some districts where all of their teachers got QPR, 60 of the staff that cut across buildings got youth mental health first aid. It's still a heavy lift in terms of the investment of district time, in terms of the resources for those staff, because it's either on an Act 80 day, an in-service day. It's typically not been voluntary where they wanted comprehensive coverage for a number of staff. So actually measuring efficacy data would be really, really valuable to make sure you're getting return on the investment along those lines. So we're right about at time. We're perfectly on time, so that's a good thing. That's a rarity, I know.